confident with it.
I can see that we have already one question in the chat. It's about the registering the event. And I can answer here that yes, the event will be registered and our offer the registration to Mila Fortuna.
Yes, you can see here, perfect. Great. It's is there any time difference with Moldavia, or is just 3:30 as for us? Is maybe one hour?
One hour.
1 hour, huh?
No.
Yeah. And your main, I mean, the official language is Romanian, or there's some Moldavian?
Yes, indeed. Yeah.
Okay.
Romanian. Some people call it Moldavian, but same. No difference.
Yes, okay.
Scientifically, no. And it's Latin.
I've been a couple of times in Romania. I have a lot of friends there for lectures, whatever, but never been there in Moldavia, which is quite close, no?
Yeah, geographically and historically, and everything. You are invited. Professor Pelosi was 2007, probably more.
No,
so
many times in that area. I have a lot of friends, so it was just curiosity. Well, and how is it going with COVID-19? You have a lot of patients right now. You're still.
It's hopefully it's plateauing, but apparently it's going up.
But you still have ICU patients. I mean, a certain number of ICU patients.
We do, and this number is going up.
Okay,
the ministry had to reopen another COVID hospital which was shut, but now they are reopening. So it's quite tough.
Yes, we had kind of two waves also here. It was a first wave in the beginning, then a second one, and this second one is usually not as big as the first, but patients are more severe because they stay home, they're afraid of going to hospital, so they come to hospital in a later stage of disease, and we saw them a little bit more sick than the first wave. But hopefully it should go down. I mean, temperature plays its role.
And people can go outside, so outside you get less chance to catch it if you. So we are learning to live with it.
Exactly. You know, when temperature goes up, it's much better also for evaporation, for everything, so that the chance of getting
like
droplets.
In flu, isn't it? Like seasonal flu.
I mean, all coronavirus have this seasonality, you know. So. And we start
but Brasilia.
Yes, but Brazil is coming winter time now. I mean, there are two factors. I saw there's interesting studies coming out now. There's some evidence that the virus is getting adapted to the host. So we can see now that the virulence and the aggressivity of the virus is lower than in early stages. So this could be other encouraging signal.
That's good. So getting used each other.
But, you know, the virus anyway needs us. I mean, if you put it in a survival perspective, the virus needs us more than we need it. We could live without, but it can't live without us. So it's quite kind of normal that any viral infection gets progressively used to the host. So let's hope it will be like this, because anyway, we are some way expecting a second wave in winter time, no? It will come, no? It's like flu. So we just have to hope that it won't be so aggressive as
do you think October?
You know, I live in Sicily, so it's in the south of Italy. And if we make a comparison, our worst period is normally December. When it's colder or whatever, we have a peak in influenza. And so we are expecting around there. But I guess, yes, end of October, November could be the peak for north of Italy, for most of Italy. This time we should be prepared. So we will see what will come. basically, I hope there won't be any second wave.
Ion, cred că putem să începem deja cu programul.
Good afternoon, ladies and gentlemen. Because the time is according to the schedule, we have to start. The colleagues that will join us, they will join us on the way. And with your permission, I would like to welcome you to the webinar entitled "In the Front Line: Exchange of Italian and Moldovan Experience in the Context of COVID in Managing Patients with COVID-19." My name is Ion Kesov. I am an anesthesiologist, and unfortunately, Professor Belli has to be right now at an emergency meeting related to COVID at the Ministry of Health of Moldova, but he will join us a little bit later. So it's my pleasure and honor to be your host today. This webinar is organized at the initiative of Italian Embassy in the Republic of Moldova in collaboration with local partners, Association of Women Entrepreneurs from Moldova, Valeriu Ghereg Medical Foundation, and MultiMed Clinic. The aim of this conference is to fuel the exchange of information on management of COVID-19 patients. And today, our notorious speakers are worldwide well-known experts in their fields. Ladies and gentlemen, it's my pleasure to introduce Matteo Bassetti, Professor of Infectious Disease, Department of Health Science, University of Genoa, Head of Infectious Disease Clinic, Hospital Policlinico San Martino, Chairperson of ESCMID Study Group for Infection in Critically Ill Patients. Maurizio Cecconi, Full Professor of Anesthesia and Intensive Care, Head of Anesthesia and Intensive Care Department at the Humanitas Research Hospital, President-elect of European Society of Intensive Care Medicine. Paolo Pelosi, Full Professor of Anesthesia and Intensive Care Medicine, Department of Surgical Science and Integrated Diagnostic, University of Genoa, Director of Anesthesia and Intensive Care Department San Martino Policlinico Hospital, Genoa, Director of Regional Poison Control Center, Genoa, Director of Specialty School in Anesthesiology and Intensive Care, Policlinico San Martino Hospital, University of Genoa. Massimiliano Bello, Professor of Anesthesia and Intensive Care, Policlinico San Marco, Cartagena, Italy, European Society of Anesthesiology Subcommittee 11 on Respiration and Airway Management Chair, and President of European Airway Management Society. And Professor Andrea Belli, Head Department of Anesthesia and Intensive Care at the Institute of Emergency Medicine from Moldova, President of Society of Anesthesiology and Reanimatology of the Republic of Moldova. Ladies and gentlemen, this meeting was launched at the initiative of Her Excellence Valeria Biagiotti, Ambassador Extraordinary and Plenipotentiary of the Italian Embassy in Chișinau. Your Excellence, Madam Ambassador, I would like to thank you for your initiative and your support, and I pass you the word.
Mulțumesc, grazie, bună ziua. I've been actually thinking about this event for a long time, so I'm really very happy that we are finally here all together. Let me first of all welcome our guests, Professors Bassetti, Cecconi, Pelosi, and Sorbello. It is not a chance that they are here today with us because their names were specifically mentioned and requested by their Moldovan colleagues. To our Italian guests, I wish to say that not only am I thanking you for being here today and for having accepted this invitation, but also for what you have done in these terrible months, having to cope with such a difficult emergency. Unfortunately, as we all know, Italy was the first European country to be severely hit by the pandemic, having to sail in unexplored seas in many cases before other countries equally sadly followed the same dynamics. Thanks to the extraordinary work of our healthcare professionals, whom I thank once again, and also to the sacrifice of citizens who had to face a very severe lockdown. Now the situation has largely improved, and we can look at the future a bit more optimistically. Of course, we know that we should not let the guard down and continue taking all necessary precautions. And at the same time, I thought it was also very important to share this experience with other countries facing the same problems, like in the case of the Republic of Moldova. Let me thank our medical officer, Ludmila Fortuna, whose role in the organization of this event has been crucial and who has transformed what was only a vague proposal from my side into something very concrete and hopefully useful. I wish also to thank the Association of Female Entrepreneurs for their logistical and technical support, and of course the Medical Foundation Valeriu Ghereg for their interest and their receptiveness to this initiative. I know we also have among us representatives from the Ministry of Health and from the University of Medicine, Testemitsanu. I wish also to welcome them, and I really hope we can have a very fruitful and useful dialogue and exchange of experience. Thank you very much. Grazie.
Thank you, Your Excellency, Madam Ambassador. And now I would like to pass the word to Dr. Ludmila Fortuna, the person without which support and without which enthusiasm, it is hard to imagine that this meeting will be possible to take place.
Buongiorno a tutti, io vi parlo in italiano e vengo con ringraziamento soprattutto verso di voi, professor Pelosi, professor Cecconi, professor Sorbello e professor Matteo Bassetti perché avete risposto molto velocemente e siamo riusciti insieme ad organizzare questo evento. Io vi ringrazio di cuore e per me Italia significa tantissimo e spero che in futuro riusciamo ad organizzare anche un congresso qui a Chișinău in Moldova insieme. Questa è la prima esperienza, però speriamo di fare anche la prossima dal vivo. Vi ringrazio e vi auguro un buon evento. Mulțumesc, Ion.
Thank you, Ludmila. So, the first case of COVID infection was registered in Moldova on 7th of March. And from that point, we passed through a 3-month marathon of epidemic. But still, let's see if our ICU units in the Republic of Moldova are ready to face the increasing number of COVID patients. And it looks like that the surge of COVID infection is still ahead in our country. I would like to invite Professor Maurizio Cecconi to share with us the experience from Italy on the organization of ICU services for treatment of COVID patients. Professor Cecconi, the stage is yours.
Thank you very much. Thank you, Ludmila. Thank you, Ambassador. Hello, Paolo, Matteo, Max. Please give me a nudge if you don't see my screen, just in case. Thank you for the invitation, and also I apologize that I will not be able to stay for the whole event. Unfortunately, there is also one of the committees in the region for the phase 2 that I need to go back to after this. So I'm really sorry, because I'm sure it will be a very nice conversation. I have been asked to talk about the ICU experience. So I will show you a little bit of the experience, especially from where I live, which is in Lombardy. But some of the stories and many of the stories that I tell from our experience are shared actually from the work of many colleagues across the whole country. Our story starts like this, and this is a very important moment in our story, because up to the 20th of February, we thought that we didn't have a significant problem with COVID-19 in Italy. Indeed, we thought that we were able to trace and to contact trace patients that were positive, either Chinese patients, the Chinese visitors, somebody that tested positive. You know, we knew pretty much everyone that was in the country, or at least we thought that we knew anyone that was in the country. On the 20th of February 2020, a patient on his 30s admitted to the intensive care unit in Codogno Hospital, Lodi in Lombardy, tested positive for a new coronavirus. This moment is crucial to understand our story. This is where Codogno is. It's a small town. Was not really much known, not even in Italy before this. It came to the media attention because exactly here, one of the anesthetists, the intensivist there, had the intuition that a young patient that was not responding to the initial treatment to a typical pneumonia and didn't have any risk factors to having been in contact with COVID-19 for what the risk factors we knew at the time, which basically meant having been in contact with somebody with COVID-19 or having traveled from China in the previous 2 weeks. She decided to force the local protocol and to ask for a PCR swab. That PCR swab became positive, and for us was really waking up with a nightmare. I'm showing you this slide. You've all seen the Johns Hopkins map of the spread of COVID-19 in different countries around the world. I took this slide when I was in America the week before the 20th of February for a conference in critical care medicine. As you see here on the left side of the graph, Italy was not even present here. What we know, however, now is that probably the virus had been circulating for weeks before. And this first case of secondary transmission was for us a wake-up call, realizing that we really had a big problem. Probably a good thing that happened immediately after that was the fact that a network of intensive care units was called, and I'll come back to that in a second. Just to give you updated numbers, you can find this infographic every day, updated from our Italian Health Institute. We have so far about 235,000 confirmed cases. Probably we know that could be many more than that in the community, but this is the positive cases. A bit more than 10% of these cases are healthcare workers, and we had about 32,000 associated deaths. When we look at case fatality rate in Italy, everyone looks at the fact that we had a high case fatality rate and compared to other countries. I think that is truth, but it's also very important to look at how the age group are distributed for case fatality rates. Indeed, if you see up to the age of 50, probably we have less than 400 deaths in the whole country. Above the age of 50, then we start to see the tragedy of many positive cases that actually died. And if you look at the mortality across Europe and the United Kingdom, but also in America now, probably that's a common theme. We don't have a vaccine for this virus at the moment. And it seems that probably one of the most important strategies is not just what we do in intensive care, which we are at the end of the process, but actually how we can protect from spreading the disease, especially the most vulnerable, the most frail parts of our societies. Indeed, when the virus is spreading in nursing homes or in patients that are older with comorbidities, the case fatality rate is indeed significantly high. As I was saying to you, the experience that we had in Lombardy on the 20th of February, probably a very important thing happened, which is the fact that the government, the local government, realized we have a problem, and probably we've underestimated the problem. This problem may lead to many sick patients being or coming to the intensive care units. So an initial meeting was held with a network of intensive care, which we were lucky to have as an infrastructure for advanced circulatory or respiratory support with extracorporeal circulation. This network was set up by Antonio Pesenti and Alberto Zangrillo some years ago. It was the backbone for our initial response. On this network, then, we started to build up a series of intensive care units. And with an initial meeting on the next 24 hours after the discovery of the first patient, we already realized that patients were already coming to our emergency department. Giacomo Grasselli and Antonio Pesenti have been leading our response in Lombardy. Just to give you an idea, I don't have the exact numbers of the first few days, but after the 21st, 22nd, and so on, we started to see 5, 10, 15, and so on. Patients that were requiring invasive mechanical ventilation. And after roughly a week of data, our initial rate of ICU admissions to the ratio of positive tests was actually quite high, in the range of 10–16% of positive cases. That was higher than what we were expecting from China. We definitely felt very surprised by this, and we felt that probably we were not prepared at the moment to manage with this. So it took an enormous effort to create extra capacity in the system. We worked on 2 key principles. One was increase surge ICU capacity and surge capacity in hospital to manage the flux of sick patients coming to the hospital, and at the same time contain the virus transmission. This is key. This is a battle that you cannot win just in intensive care. It's contain the virus transmission, both in the community and in the hospitals. So what we were able to see after 9 days of data was that really we were in an exponential phase of growth of ICU admissions. And this is just an extrapolation done by Professor Stefano Merler from the Foundation Bruno Kessler in Trento, that have been modeling our pandemic. Here on the 5th of March, which was when we were asking the government to put stringent maneuvers in terms of lockdown or quarantine of some areas in Lombardy, and then also it happens also in the whole country, we saw that if the spread of the disease was not stopped, there was a potential, now this is clearly a mathematical extrapolation, but a potential for a very large number of ICU admissions. Now, the lockdown was put in place, we saw a very large number of admissions, we never reached a linear growth, the growth was still exponential, but we peaked at something that was roughly 1,500 occupied ICU beds for COVID-19 in the area. During those days, we realized that the surprise of this virus for us in this uncontrolled cluster was so violent that we probably had to send a message out to other parts of the world. So we did send this letter with the European Society of Intensive Care Medicine. It went to many contacts around the world. It was read by some news, and we were able to pass some other messages. As many other people in this call today, we tried to basically to tell other people around the world, get ready. Our get ready was on very simple principles, only the things that we thought helped us to really to try to cope with this large number of patients that was coming to us. And again, it was increase the capacity, work on containment in community, in hospitals, do not work in silos. It took the whole effort of the whole hospital, from management, from engineers. I remember being at 3 o'clock at night looking at what was the maximum oxygen flow capacity in some wards to put some extra CPAP machines. We used a lot of training and simulation, and always keep some very key principles. Protect patients, the ones that are not positive, from becoming infected, and also other healthcare workers as well, because that's also very crucial. We could not we cannot afford really to give the disease to healthcare workers. The first hospitals that we didn't realize that they had the clusters, they had a tragedy to have a lot of healthcare workers infected. Luckily, this didn't happen in many other places after that, but there was certainly something that was worrying us a lot. Also because at the beginning, we didn't have the data from China knowing how sick healthcare workers were coming from the disease. As I was saying to you before, this is the data from Lombardy, courtesy of Giacomo Grasselli, that has been coordinating this effort. We started with 720 ICU beds in the region. Now, in Italy, we classify ICU beds as beds where you can provide invasive mechanical ventilation. On top of these ICU beds, we did deliver a lot of intensive care in the country by supporting other wards with non-invasive ventilation and CPAP outside of the intensive care. Just to give you some ratios of what happened in Lombardy, we started with 720 open beds. It's the middle of winter. The total occupancy is probably around 95%. So we were probably running with 30, 40 beds available when we discovered the problem. We stopped elective surgery immediately to have some extra capacity. And then we started to build ICU beds in recovery rooms, in operating rooms, and so on. The maximum peak of invasive mechanical ventilation that came in a single day to the area was 151 patients, roughly in the middle, latest part of March. And on the 2nd of April, we peaked at 1,500 occupied beds for COVID-19. On top of this, we also protected 300 beds that were completely isolated from COVID-19 to cope with all the other emergency, trauma, strokes, myocardial infarctions, and so on and so on. Overall, we've treated so far in the last 3 months, but mainly, I would say, in the months of the end of February, March, April, and part of May, something like 4,500, between 4,500 to 5,000 invasively mechanically ventilated patients. On top of that, you have to add all the extra patients that we treated with non-invasive ventilation and CPAP. So probably our total capacity for respiratory support went from around 800 beds to something like 4,000 beds in the whole region. And that really was a massive effort that we all had to take. People were often asking, were these patients sick? Well, actually, they were very sick. This is just the first 1,600 patients admitted to the region. The PO2 FiO2 is a ratio that we looked, and I'm sure that Paolo will explain more about ventilation strategies later. But basically, it is a variable that we look to understand how bad the respiratory failure is. Anything below 200 is bad, and anything below 150 is really bad, very severe. And as you see, really, the initial group of patients that we treated had a very significant degree of hypoxia that we had to cope with. I'm showing you some slides also because I want to show you the effort that was put in the whole country. And I know that this is reflected also in other parts of the country, not just Lombardy. There have been a lot of talks of the fact that we were struggling with beds and maybe people were making choices. I do really believe that the only choice that we made as a clinical community, not just intensive care doctor, infectious disease doctors, really everyone working in healthcare, was to try to give a bed to whoever needed a bed and was benefiting from this bed. This is the median age of our population when we were very stretched. It is 63 years of age. It's exactly the median population of what I showed you at the beginning of the spread of the disease in Italy, which is again 62 years of age. So age was not a risk factor to come to our intensive care units. Of course, being old and frail meant that these patients were more likely to die compared to younger patients. I'm going to conclude showing you a little bit of my experience in my hospital. One of the things that I did find extremely useful was bringing a simulation team in situ to teach people how to do donning and doffing, so the procedures to put the gear and to remove the gear properly. Immediately, we separated patient flows for all the patients that were suspected cases. This is crucial to, again, to protect non-COVID-19 patients and healthcare workers. This was our initial approach. It changed a little bit over the weeks, but the principles have stayed the same. And this is a principle that every hospital in Italy is taking. Really, the separation of flow is absolutely crucial to avoid having clusters for patients and for healthcare workers in the hospitals. I did find training and simulation being particularly useful. On the 22nd of February, we were spending time for the next 48 hours simulating in a new area, and we trained 80 clinicians to donning, doffing, intubating, and proning with completely different gear, something that we were not used to do before. We used random drills, and we were also able to convince the hospital to have a safety officer. So this person here, I think, helped us a lot. It was a shift that was in charge to supervise the donning and the doffing of the procedure, especially the doffing. We know from previous experience from other outbreaks like Ebola, that the most dangerous part of the procedure is not when you put the gear on, but actually when you remove the gear after maybe having been exposed to viral load, and your gear can be contaminated. Another thing that was very important in our experience to deliver intensive care was going out of the walls of the intensive care. In Italy, we have a long tradition of CPAP and helmet CPAP. We did deliver a lot of this outside in the wards. This was not done instead of invasive mechanical ventilation, was done where in those patients that we thought it was appropriate to use CPAP. Sometimes we use CPAP before intubation. Some patients were managed just on CPAP, and we're now analyzing some data to look at how this was done. I'm saying this because at the beginning there were some news from some other parts of the world saying you should never use CPAP of non-invasive ventilations in these patients. I actually decided, exactly because I was in front of the disease that I didn't know, not to change my approach to these patients, but actually to be ready to decide case on case which patient could benefit from CPAP, which patient maybe would benefit from an early intubation. The important thing is not to delay intubation, but it's not true that there were not some patients that could be managed safely with non-invasive techniques and especially with CPAP. These are my last slides. What I would say is that it was an enormous effort, but I know that the clinical and scientific community really got together. We had to work in things that never worked together before to increase our capacity so much. We had to put in place even techniques, how to do team briefings at the beginning to introduce each other, to know if somebody's ever worked in the intensive care before. Maybe some nurses were coming from clinics that they'd never seen a sick patient before. There was a great moment of learning and teaching and supervising and trying to be part of a group. We were a bit scared, but we were also very proud to try to give an answer to this massive tragedy that hit our country. And there were also some nice moments. We all remember, I'm sure the other speaker will say the same, but we all remember the first moments where the first patient became extubated and suddenly can speak on the phones, maybe with the families again. It is been very tough, especially because we were used to work in a way that is not our standard way of working. Normally in these days now, in these years, families are part of the healing process. They're there with us at the bedside. And as you know, and I'm sure it happened also in your country, we had to restrict visits of families. Families could not be there at bedside. So in a way, we became family for these patients. We were the ones there with the healing process. And sometimes, unfortunately, we were the last one holding their hands when these patients were dying. And I would like to conclude just showing you some pictures of my team and the team here in the hospitals where I work. I think it's being really thanks to the effort of every healthcare worker in Italy that we've been able to give an answer, I would say, to something that has been the biggest surprise. And I would say personally it's been the biggest challenge clinically of my career so far. Thank you.
Thank you, Professor Cecconi, for your presentation, for your emotional presentation. If there are any questions, please send us them on Facebook or via Zoom. You can ask questions in Romanian and we will translate them. So far, I would like to mention that in the Republic of Moldova, we have several hospitals that were specifically designed to serve COVID patients. And we tried to keep safe hospitals, free COVID hospitals, but unfortunately we didn't manage to do it. And almost in all COVID free hospitals, we had cases of COVID that later were transferred to COVID centers. Unfortunately, the rate of action among the healthcare workers is quite high. Around 20% of all COVID positive patients in Moldova, these are healthcare workers. And these statistics really disappoint us. We tried, at least in several hospitals, COVID hospitals, to start training on doffing and donning of the equipment 2 weeks before our first patient arrived. And at least in ICU departments, we have quite low rate of infection among healthcare workers. But in the departments where we were not able to provide training like this, the situation is really dramatic. And the same problem, as you mentioned, we are not allowing the relative to comes into the words, and these create a huge psychological stress for the patients because they are somehow isolated from their relatives and friends.
I think it's a very similar experience to what we see in Italy. I would say that probably because everyone was so focused on the fact that sick patients would come to our intensive care units, we did put a lot of effort in training and doing proper donning and doffing, and to have a lot of personal protective equipment. Anecdotally, we don't have data now collected everywhere systemically. We do actually, but we've not analyzed it that very well. But anecdotally, those wards where you knew that you had COVID patient, they seem to have been safer for the infection on healthcare workers compared to other places. We find exactly the same, that maybe in some wards where people didn't think that there was a case, we saw more doctors and more nurses becoming infected. Or for instance, we saw in the community general practitioners or clinics where you had a lot of flow of patients coming in and out, and maybe you didn't know that they were positive because we had a lot of asymptomatic cases, and we still have. Probably those were some of the risk factors that we didn't consider, but I think it's similar everywhere in the world. And I would argue that probably we realized that the intensive care, the COVID-19 intensive care area were very safe places to work when you knew that the problem was there and you were doing all the efforts to protect your workers.
Thank you once again, Professor Cicconi. We know that you have to leave us, unfortunately. I wish you a nice evening, and once again, thank you for your commitment and for your decision to share your experience with us. Thank you so much.
Thank you very much for asking me, and I apologize I have to leave. I'm sure it will be a very nice conference. Thank you.
Thank you. And dear colleagues, now let's move forward. Unfortunately, we will do a change in our program, and we will ask now Professor Massimiliano to ask when we should think about and we should proceed about intubation of our COVID-19 positive patients, and what he can advise us about the option during the intubation maneuvers. Professor Sabello, please, the stage is yours.
Good evening to everybody. Ciao Maurizio, good work and thanks for your talk. I'm now going to share my screen. Okay. Okay, can you see my screen? Is it okay?
Yes.
Perfect. So, thank you everybody. Thank you to my colleague Ludmila Fortuna. Thank you to Her Excellency Ambassador. It's a privilege and an honor to be here together with my friends from Italy. And it's also a pleasure for me to try to share our experience with particular reference to intubation, personal protective equipment, and some clinical advices. So I need to declare a series of conflict of interest. It's more or less regarding any company in our management, so my talk won't be influenced by this. And my first slide is for sure to remind what happened in Italy. As the ambassador said, the first European country to be severely hit by COVID-19. We had a lot of cases, we had a lot of death. It was a huge challenge for the healthcare system. The Lombardia system, which was claimed to be one of the most advanced in Europe, was badly hit, and despite a great organization, there were troubles, dead people, and a lot of big challenges that I think we face in the best possible way. It was hard times for doctors. Anesthesiologists for first time went on the cover of Time. This was one guy from Ravenna. A lot of people, any healthcare worker, from anesthesiologist, nurse, any doctor, whoever was involved in this fight, and these data which are updated to June 3, so just a couple of days ago, just highlight that 12% of total known infected people are within healthcare workers, and we had a casualty rate with more than 167 doctors dead because of now COVID-19 or during COVID-19, which is an important number. So to them, our memory and respect, and honor and respect also to people like Paolo Pelosi or Professor Bassetti or Maurizio, who were, I think all of us gave our contribution, these heroes in first line in this fight. So it's really a pleasure for me to be here and honor to share our knowledge and our experience. So very briefly, we will go through the concept of personal protective equipment, how we take the decision to intubate, which issues with our management, and just a spot for complication, because it's something that we are learning also with COVID-19. These are just some movies, and basically when we watch this movie, we could have never thought that we could look someday like Dustin Hoffman. So we look at him like an alien in this strange suit with positive pressure. We were looking at these movies just like movies, and all at once we found ourselves in the same scenario. And anesthesiologists were at highest risk than other doctors because we were called to move in the den of the beast. So we want to deal with highways, and the highway is the site where we can find the highest viral load in severely symptomatic patients. It's been calculated that viral load in severely symptomatic patients' highways can be 60 times more than non-symptomatic patients. So this means that any airway maneuver has an increased risk of complications and infection for healthcare workers. Staying from this position, the first issue that we had to deal was trying to understand the concept of personal protective equipment. We won't have long time to discuss it, but I recommend this paper. It was published by a Canadian group with Laura Duggan and Shannon Lockhart. It's very well done. It gives a complete overview, but above all, it makes the most important difference for COVID-19 and healthcare workers, which is the difference between the large droplets, which is something that everybody is exposed, for example, during sneezing or coughing or whatever, small droplets, which can be observed also during speaking aloud or whatever, but all of these stays in a smaller range. Then we have the small infectious droplet nuclei, which are the so-called aerosols. This is what we need to be more defended as anesthesiologists, as people in charge for our management, because this is the level of protection to protect ourselves from this level of attack is the highest possible. So we learn to be familiar with different masks, and or better to call them respirators, and with the big confusion which was around them, because not all masks and respirators are the same, and some of them are different based on different certifications. So what is a certain level of protection in China is not the same level of protection in the US or in Europe. So we had to deal also with this, and basically we had to come to the concept that for the first time probably in our career, when we are dealing with COVID-19 patients, the first priority is our protection. So we come before the patient for a simple concept. The more we resist as doctors, the more the people that we can help. So it's fundamental that we get the highest level of protection. And when we face the unknown, because still today, we are not sure about the airborne diffusion of the virus, we are not sure about the survival time on some cases. So in all these cases, we need to be particularly careful. So we speak about aerosol generating procedures, which is extubation, intubation, front of neck, awake tracheal intubation, bronchoscopy, high flow nasal oxygen, face mask ventilation, suction. And when we deal with this kind of procedures, then we need to move our protection level to the airborne level. This means, and you can see here some videos and pictures, that you need the total suit, double glove, you need to be covered any part of your body, you need goggles, you need a FFP3 mask or FFP2 if you don't have, you need underclothes, which is single use, and you need to take particular care with hygiene, hands hygiene, disinfection, and surfaces that you touch. In this picture, you can also see different settings, so you can see some alternative settings with a face shield and N95 mask, and you can see a full suit of a PAPR, so a system with purified air with positive pressure, which is here coming from my colleague in Bologna. All these pictures here, they represent an airborne level of protection, and this level of protection is recommended for any aerosol generating procedures. And we need also to consider some alternatives. There's been a lot of discussion about the so-called barrier enclosures. You see here in the middle the important paper by Canelli, which went to New England and which caused an explosion of the ideas of airway box. There's a lot of literature, a lot of publications. There's people who are using tents, plastic covers. There's a lot of space also for the handmade. All this picture here come from single hospital initiatives, from donations, from architects who designed also these specific covers, but we don't know exactly what is the truth. I have to thank my very good friend, Rossoff Meyer. You see here, this lady is vaping inside an airway box, and this could be empiric demonstration that these boxes protect from large droplets, but maybe they don't protect from aerosolization. And we just submitted to the BJA a scoping review comparing all papers about these barrier enclosures with the recommendation of trusting and relying on certified PPE and not on these alternatives. So if you don't have nothing else, adopt the best level of PPE that you could use, but don't trust these devices because they are not yet certified. We don't have any warrant that they are effective in preventing at least the airborne spreading of the virus. I think it's even more important, this is something that we learned on our skin, to adequately protect the non-clinical areas of work, because fomites can be a source of infection, so you should be particularly careful to cover your devices in OR, to protect or to disposal any airway device when you don't use it, or to set up a specific systems to protect the health of the colleagues when you go for some meeting, when you discuss clinical cases or something like this. Intubation and decision to intubate is probably something completely new for us when COVID-19 started to spread so fast, because it put us in front of similar patients. So patients who were maybe already on some CPAP, on some helmet, you look at them, you could easily speak to them. You couldn't imagine they were so sick until when you didn't look at the blood gas. So this was a patient who was speaking, talking, whatever, and his ratio, his PF was 100 despite being on 80% oxygen on CPAP. So this is a totally new scenario for airway managers, because we were used to deal with patients which were not aware, which were unconscious or whatever. These were people to whom we had to tell, I need to intubate you. And this original picture of hypoxemia, of severe hypoxemia and normocarbia or hypocarbia, we found out to be already described in aviation medicine. So this is something that we went back to learn from the basics. And this is something which results also in a complete new approach with airway management. First of all, we were wearing PPE. Second, we understood that all these patients could be difficult intubation for some reasons. And last but not least, we discovered the second victim effect. This is a very good friend of mine, is Andy Higgs, one of the authors of the ICU guidelines from UK. And he described his first intubation in a 60-year-old guy like one of the worst intubation in his life, because he had tears in his eyes, because this person was asking him not to intubate because he knew that he could die. So this is something which we saw in all healthcare providers, and this is something that we will fight or that we will deal with in the next months. So if you are not here, get prepared to face the burnout, to face depression or psychological symptoms which could occur in so many healthcares who had so heavy and stressful experiences. But let's go back to what we speak today. This is a great paper from Paolo and from his group. He will discuss it, but facing COVID-19, we find out that it's a different RDS, that we need to treat differently these patients. We found out that we could use the non-invasive ventilation also in prone position, and this was happening in Palermo here in Sicily, this was happening in Serbia, as you see in the other picture. So we had to change our practice, and also we had to redraw our airway management protocols. So this was published by SIAT in the early beginning of pandemic, by mid-March in Italy. It went translated into 5 languages. You can download it for free, translate into your language, make any adaptation, because this is just something which reminds you what is different for a manager with COVID-19 patients. And if we start from this, I think the most important issue is the decision to intubate. we came to the conclusion that the best way to understand if our patients had to be intubated was going the so-called MIV trial. So failure of spontaneous breathing with oxygen supplementation, given a certain positive pressure ventilation or CPAP, or maybe pressure support. But if all of this didn't come to a certain output, to a certain goal within 1 hour, 2 hours, then there was decision for intubation in a patient that you would not intubate clinically, because if you look at the patient and say, but how, he doesn't deserve intubation, then you look at blood gas, then you look at 1 hour or 2 hours of 10 centimeters of water, CPAP, they don't work, and then you decide to intubate. The background of all of this is mostly the concept of trying to make every COVID intubation like elective, because these are difficult intubation. They can be difficult to intubate classically, but they're difficult to intubate because you are wearing PPE. You are doing this in a patient which is fastly deteriorating. You are doing all of this in an unfamiliar environment with people that you don't even see who are, because they are covered with PPE, so you can't even call them by name. You are in emergency. You are with psychological issues of getting infected. So if we anticipate this intubation, if we try to make it elective, we improve the performance, because we can do it in a patient which is still stable. We can do it discussing in advance what to do and planning everything. And the same principle is maximizing first pass success. We know that we can have lower results as soon as we provide the repeated laryngoscopic attempts. So our proposal was optimize hemodynamics, work on pre-oxygenation, and use the best setting for your first attempt. So we recommended the video laryngoscope plus introducer on first laryngoscopy independently on prediction of difficulty, so that you could maximize first pass success. You can see all of this here. This is part of the protocol, so we recommended pre-oxygenation to all patients. Might it be with conventional oxygen? Might it be with CPAP? We did not recommend use of high flow nasal oxygen because there's still some doubts about viral spreading. We did not recommend cricoid pressure unless unavoidable. We strongly recommend the rapid sequence with full dose neuromuscular blocking agents, so to avoid any coughing or reaction or aerosol generating procedure. We discourage face mask ventilation, so excellent pre-oxygenation, apnea until intubation, maximization of first success. If you need to ventilate, to be very gentle, very slow, with double filter settings on your oxygenation devices and everything. If you fail first laryngoscopy, if you fail second laryngoscopy, don't insist. So we anticipated at 2 failures, the idea of using a supraglottic airway, not as a definitive airway, but as a bridge for fiber optic intubation. And we also recommended early access to cricothyrotomy if we don't see other alternatives independently on saturation. The awake tracheal intubation is strongly discouraged in any guideline because it's within the most, the highest ranked aerosol generating procedure. So reserve it only for extremely limited cases, and being particularly careful to have the best and the most expert operator at the head of the patient, so to minimize, to do every procedure in the best way, to minimize aerosolization and to minimize the risk of infection. Be extremely careful also with tube position, because you can't use your stethoscope, your vision is blurred. So trust only on capnography, trust only on ultrasound and expert hands, so to see the tube within vocal cords, to see the lung sliding, to see this bilateral and everything, because you can't rely on stethoscope. It has some limit normally. It has much more when you are wearing PPE, where you don't see good, and all the rest. And one important lesson that we learned is from this picture. This comes from a very good friend, anesthesiologist in Vicenza. The hashtag says, no one gets saved alone. So COVID-19 taught us the importance of teamwork. And also in our guidelines, we suggested the role of teamwork with pre-operative, with pre-procedural discussion. Everything should be discussed before. You don't need to have improvisation. You need to give roles, tasks. You need to have a short team, a small team with a most expert leading. You have a limit in communication. You have a limit in reaction. So the smallest possible team, the highest expert, everything discussed before, including the position around the bed, so that you minimize unnecessary movement, unnecessary disconnection. And this works only if you make this intubation elective. So if you prepare it rather than waiting to go in emergency. We also encourage the use of acronyms, of checklists, of cognitive aids, because in this setting in which everything is unfamiliar, the psychological pressure is high, we need to have something which keeps us always with our feet on the ground, which gives us back the idea of what we are doing, where we should go, and what to do if something goes wrong. Because we're in a setting in which the emotional load, the task skills, and everything is high. So we need to rely on few things and very clear. What we learned, what is coming for the future, I think that the biggest effort, the biggest challenges will be getting back to normal in a phase 2, where it will be difficult to find out the suspect cases, how to behave with normal patients, if to treat them like potential positive. So this will be one challenge. Important challenge will be developing clinical risk scores, something that helps us anticipating the outcome, anticipating which patients might benefit of intubation, and all of this. And looking at the autopsies, looking at the mechanism of disease that we will learn with time, I think it will be extremely important to understand an interesting phenomenon which I try to depict like this. I think all of you recognize these scenes from The Godfather. So you see that the boss, you see that Al Pacino here is wearing no weapons. He has a bodyguard who is armed. And what we saw with the virus is exactly the same. So the virus is the boss, is not with weapons. It's the immune system to be the killer, the variable responder, or the variable mean through which this affects different parts of the body in different ways in different subjects. So starting from this point, the more we will learn, the best we will start to treat the infection and the virus. This happens also for airways. And for example, we saw, and it's coming from many cases, from many reports, a higher number than normal of pneumomediastinum, of pneumothorax, of tracheal lesions following intubation or airway management. So this is just a nice short review, but it's 5 cases in a single period during normal intubation in COVID-19 patients. So probably when we face the eye of these patients, there's a series of things which are happening. And if we look at all the airway, probably we can have some damage related to intubation because we use PPE. So we are less sensible. We have blurred vision. We probably use bougie, video laryngoscope. We are not prepared. We have psychological factor like fear of infection. So you try to go in anyway. And this could result in higher incidence of airway lesions. We have ventilation, and this is my hook for the next speaker. We have ventilation because higher pressures or high PEEP or a new modality of ventilation could induce trauma in these lungs or in these airways, especially because COVID-19 causes inflammation, maybe mucosa is more frayed, maybe endothelitis, maybe something changes in these airways. So it's difficult intubation, it's a difficult setting, and it's also a setting in which there is a higher risk of airway trauma. So I hope that all this information can give you some practical tips and tricks, can give you some important message to deliver. And I think that the most important is work on preventing things. So work on team, work on communication, work on preparedness, because everything you have to do is totally different from how you are used to do. So try to do it in the best way and looking faithfully at the future with the eyes of my princess Sophia, my daughter here, and hoping that I put it to this stay safe also in the right way in your language. Thanks again for inviting me and for the honor of being here.
Thank you very much, Professor Sobel, for your presentation. And we have a question related to video laryngoscopy. So actually, yes, in Republic of Moldova, the first video laryngoscope that was provided to a hospital, it was the one that was during the COVID pandemic. And almost no one had it. Makes sense to use the laryngoscopy, or should we stick to the ordinary laryngoscope?
Okay, the point is this. Video laryngoscope has two important advantages. The first one is that we have evidence from literature that it can improve intubation success. So it makes easier for us to deal with a difficult airway. So it has an advantage. Second advantage is that if we use a screen, we don't need to get close to the patient. So there's also a nice paper which went published to anesthesia, which demonstrated that average distance between the anesthesiologist and the airway is increased when you use a video laryngoscope rather than using a Macintosh. But the point is, first of all, you should have a video laryngoscope. Second, most important, you need to know how to use it. Because if you start using a device that you're not familiar with, you do it in the worst possible scenario, which is the COVID-19 patient. So if you have these devices, start using them, get familiar and use. But if you don't feel confident, Macintosh is still an excellent device. Use it with a bougie so that you maximize first pass success. Couple it with a tracheal introducer. Put yourself in the best condition with pre-oxygenation and with other issues. Give the patient the most expert intubator. And meantime, get confident with video laryngoscope. I'm sure that one of the side effects of this pandemic will be a larger diffusion of these devices. And if we will have more people will get confident with them and we will be prepared for the future. And that's my opinion.
Thank you, Professor Massimiliano Sabello, for your exhaustive answer. And now I pass the word to Professor Matteo Bossetti, that is going to talk about anti-infective management of COVID-19 patients. Professor Matteo, welcome you. We welcome you.
So, thank you. So let me share my screen. Okay. Could you see the screen? Hello?
Yes, we can see it.
Fine? Okay. So thank you very much for the invitation. So my task is to talk about the challenges in the management of the COVID-19 patients with a focus on anti-infective treatment for this disease. So these are my disclosures, but let's start with the three major points, in my opinion, in the management of COVID-19. So we have a very important point regarding diagnosis, and I know that somebody before me already talked about initial presentation, the clinical features, and the micro tests and imaging. Then I will talk a little bit about the spectrum of illness, and particularly about the severity of the disease and the different risk factors and complications. And then obviously I would talk about the patient management with more about the different interventions, the different experimental therapies, and also at the end, if I have time, also about the potential co-infections, talking about bacterial infection. So starting from the first important point, in my opinion, is that regarding diagnosis, I like to underline very briefly about the samples that can be collected, because in Italy, there has been an important discussion in the past 3 months regarding which is the best sample to be performed for diagnosis of COVID-19. And we know that the samples that can be obtained obviously are the lower respiratory tract, the sputum, the nasopharyngeal swab, and the oropharyngeal swab. However, we have to look at which is the corona testing positivity rate, I mean, the sensitivity of the different tests. And as you can see, when we talk about the different tests, you can see that the best test actually available is represented by the BAL, so the bronchoalveolar lavage, that is positive more than 90% of the cases. So don't forget that with the nasal swabs or with the pharyngeal swabs, we have more or less 60% of the cases positive. That means that we have more or less 40% of false negative when we do the traditional nasopharyngeal swab. Regarding the spectrum of illness, we know that this is the disease course. In general, we have more than 80, 85, probably 90% that are mild cases or asymptomatic cases. And we have more or less between 10 to 20% of severe cases, and just less than 5% are critically ill patients. And when we talk about the classification of the patients, we have to take into account that the mild cases are in general patients that present mild clinical symptoms with no lung involvement at chest imaging. And in general, the common signs and symptoms are fever and respiratory symptoms. Then we have the severe cases with tachypnea and with the P over F lower than 300, and then with a rapid radiological evolution. And then we have the very severe cases that in general, the patient that need for mechanical ventilation, septic shock, and multi-organ failure. So when we look at the disease course, this is an important point. When is the time in which the patient is in general admitted to the hospital, and what is the time in which in general the patient is transferred to the ICU and is in general intubated? So this is a natural course of the disease. So in general, the patients were admitted in the hospital between 7 and 10 days after the onset of the symptom. So they develop dyspnea and acute respiratory distress syndrome between day 10 and day 14. That is in general the time in which they have the admission to the ICU. And you can see here, so in general, we have admission in the ICU around between day 12 to day 15 after the onset of the disease. It's very important to consider that the more problematic time for COVID-19 is between day 10 to day 14. So it is important to observe the patients accurately between day 10 to day 14. Don't send the patient home, otherwise maybe they have some problem at home that is probably very problematic for them. So when we look at the complications, and this is the complication report on unselected series of COVID-19. So this is our experience that is going to be published in Clinical Microbiology and Infection soon. And in our case series, in which we include also the patients managed by in collaboration with Paolo Pelosi, with my friend Paolo, we have 36% of RDS. We have around 3% of patients in CRRT, around 5% in septic shock, and at the end, we report around 19% of patients with mechanically ventilated. So this is the highest proportion of patients with mechanically ventilated. And when we analyze the risk factors for mortality, at least in our series, we found that high level of IL-6, the development of RDS, and the heart disease and the age were all associated with an increased risk of mortality. So it's important, in my opinion, to be to take carefully the patients that present the following risk factors. So when we look at the patient management, so it's very important to consider the 3 different stages of the COVID-19 disease. So this is a very nice picture in which you understand very well where we have to do something and how to do. In the stage 1, in general, in the early infection, we have a very high viral response phase in which we have a very high viral load, in which we have some typical signs represented by lymphopenia, by increased prothrombin and increase in the dimer. And obviously, in this particular phase, it's probably more important to use antiviral drugs. Then we have the second phase, that is the stage 2, in which we have the pulmonary phase, in which obviously we have some important problem with abnormality at the chest imaging, and this is probably the time in which is important maybe to use of the corticosteroids. And then we have the stage 3, in which we have the hyperinflammation phase, in which we have high level of IL-6, in which is important probably to use the JAK inhibitors or the IL-6 inhibitor or the IL-2 inhibitor. So these are the 3 different phases in which we have to have 3 different behaviors. So this is the protocol that we decided to develop in San Martino Hospital at the beginning of March. So after the first cases, we decided to present this protocol to our ethics committee. And we have used this protocol for several weeks. An anti-HIV drugs plus hydroxychloroquine plus remdesivir when available in the site of compassionate use. Ceftaroline as the beginning for covering staphylococcal and pneumococcal bacteria, and tocilizumab in patients that present high level of IL-6 and also methylprednisone. I like to share with you the reason why we developed with this protocol at the beginning. So remdesivir is a very interesting drug with a very high activity against coronavirus, not only coronavirus 2, but even coronavirus 1 and MERS-CoV, and they present some favorable effects in animal with the MERS model. And in the first phase, we have used remdesivir in the compassionate administration. So now we have also some very good data. This is a report that has been published a few weeks ago by Dr. Bagel in New England Journal of Medicine, in which they report some preliminary data about the use of remdesivir in US. And you can see very well that these are all the data, and these are all the endpoints in favor of remdesivir. And as you can see that in the majority of the patients, there was a benefit in using remdesivir compared to the placebo, particularly in all patients, but particularly in patients even with a very difficult disease. And you can see particularly high improvement in younger, but even in older patients, so where we have all in favor of remdesivir. For this reason, the drug has been approved by FDA in US, and based on the Italian recommendation. So this is a position paper that we published in the CMI in 2020, the Journal of the European Society of Clinical Microbiology and Infectious Diseases, in which I was the first author, but there were a lot of other Italians. Remdesivir should be currently used for treating COVID-19 patients only within randomized clinical trial and the compassionate expanded access program owing to its investigational nature of the study. So when you look at other options, what do we know about hydroxychloroquine and chlorhexidine? So the rationale is the drug present antiviral activity and immunomodulatory effects. And the first profile was that was less toxic of hydroxychloroquine and more potent in vitro against SARS-CoV-2. So this is the reason why we decided to use more chloroquine. Which are the data about hydroxychloroquine? So the first study was published in BMJ, was an American study in which they compared hydroxychloroquine with hydroxychloroquine plus azithromycin and a group without hydroxychloroquine. And when you look at the mortality data, you can see very well that the mortality was higher for patients treated with hydroxychloroquine compared to patients treated with a combination with an antibiotic, compared to patients without any other drug, and with the P that was statistically significant. This was the first study that was in some manner against hydroxychloroquine. So the conclusion of the study were that there was no evidence that use of hydroxychloroquine, either with or without azithromycin, reduced the risk of mechanical ventilation, and an association of the increased overall mortality was identified in patients treated with hydroxychloroquine. After this study in Geneva, we decided to stop the use of hydroxychloroquine in hospitalized patients. But then other studies. The second one was published in New England Journal of Medicine, in which this was an observational study of hydroxychloroquine in hospitalized patients. And as you can see, no significant association between hydroxychloroquine use and intubation or death. So no improvement with the use of hydroxychloroquine in this study. The second trial was published again in New England Journal of Medicine. There was the post-exposure prophylaxis with hydroxychloroquine, and the primary endpoint was no cases confirmed in the lab. And when we look at the data, unfortunately, as you can see, there were no benefit. Development of COVID-19 did not differ significantly between groups. So no impact on patients that then, on subjects that then develop COVID-19 after the post-exposure prophylaxis. The last two studies that I like to review with you are two studies for which there was a lot of polemic in the world, and the one was published in Lancet, for which there were a couple of editorials because of the database was not public. And in this trial published in Lancet, they demonstrate that using hydroxychloroquine increased the risk of mortality and increased also the risk of ventricular arrhythmia. So obviously this was a multinational registry analysis. There are several biases in this study. The last article that I like to show with you that is not published but has been presented recently is the recovery trial, that is the randomized evaluation of COVID-19 therapy, in which they randomize more than they include more than 11,000 patients from 175 NIH hospital in UK, and at the end they randomize more than 1,500 patients to hydroxychloroquine, and they compare with 3,100 patients to user care alone. And the conclusion of the study were that there was no significant difference in the primary endpoint of 28-day mortality, and there was also no evidence of beneficial effect on hospital stay duration or other outcome. For this reason, I recommend not to use anymore hydroxychloroquine in hospitalized patients and even outside the hospital. And our guidelines, our position paper said that for this reason, hydroxychloroquine should be preferentially administered within the framework of investigational study. So if you have any investigational study, you can use hydroxychloroquine. If not, my idea is to discourage the use of hydroxychloroquine, the management of COVID-19. What do we know about tocilizumab? Tocilizumab is a recombinant humanized monoclonal antibody inhibiting IL-6 receptor. And the rationale is that the COVID-19 patients may develop secondary hemophagocytic lymphohistiocytosis and under-recognized hyperinflammatory syndrome. We know very well that it is the so-called phase 3, between phase 2 and phase 3 of the disease. What do we know about tocilizumab? The first experience published from Chinese colleagues were published in PNAS, and they understood that within 5 days after tocilizumab, 15/20 had lowered their oxygen intake, and one patient needed no oxygen therapy. And this was one of the first report about the efficacy of tocilizumab. After that, there was another report in JAMA by Dr. Shen, in which you can see very well that the patients treated with the tocilizumab present, no, sorry, this is a convalescent plasma, you know, I have to show you later on. So the experience was in Journal of Medical Virology, the single center experience. There was a reduction in almost all patients of CRP, and there was also a reduction in the overall mortality. So this is our experience in my center, in which we have used methylprednisone, tocilizumab, and the combination of methylprednisone and tocilizumab. You have here the patients, and I like to show you the data because they are very interesting. This is the Kaplan-Meier of survival, and you can see that the combination of tocilizumab plus steroids increase the probability of survival. So actually, in my center, we are using tocilizumab in combination with steroids. And in our position paper, we recommend to use tocilizumab, and tocilizumab should be preferentially used in randomized clinical trial. However, off-label use according to local protocol and consent procedure may be considered only in those COVID-19 patients excluded from randomized clinical trial or who are worsening while receiving standard supportive care. So this is my impression, our impression for use of tocilizumab. What do we know about plasma? The convalescent plasma is a possibility, has been used in the past for Ebola and even for poliomyelitis and many other diseases. So there are some anecdotal reports in favor of the plasma. However, we don't have enough data to support the use outside of randomized clinical trials. So my suggestion is that please, if you decide to use the plasma, you can do that, but please do inside of randomized clinical trial. And these are some of the effects of the convalescent plasma report in the literature. So moving to other possibilities of treatment, steroids. I discussed before the role of the steroids, and the first report was published in JAMA, Internal Medicine, at the beginning of the year, in which the authors concluded that no randomized clinical trial has been concluded on the corticosteroids administration in COVID-19, and there are controversial opinions regarding extrapolations from previous studies in SARS-CoV-1 and MERS-CoV patients. In an observational study in 84 COVID-19 with RDS in China, methylprednisolone was associated with reduction progression to death. I like to show you the data, and they are quite very good. And these are the data regarding the potential role of methylprednisolone comparing to patients without methylprednisolone. After this study, we decide to include in our center the methylprednisolone for our patients. And the conclusion of our position paper were in favor of the use of the corticosteroids. So considering the overwhelming inflammation and cytokine-related lung injury might be responsible for rapidly progressing pneumonia and the clinical deterioration of COVID-19 patients, we suggest to consider administration of corticosteroids in critically ill COVID-19 patients with RDS and with worsening of non-RDS respiratory failure in the absence of bacteria, fungal, and superinfection. So we generally recommend the use of the steroids in this kind of patients. So this is our protocol now. We don't have any more darunavir, ritonavir, and hydroxychloroquine inside of our protocol. We still have remdesivir inside of the expanded access program and compassionate use. We still use ceftaroline in the first 5 days of treatment after the patient is admitted to the hospital. We use when we have a very high level of IL-6 tocilizumab, and we use methylprednisolone 1-2 milligram kilo days for at least 5 days, but even longer. Then probably Paolo Pelosi can discuss about the strategy inside of the ICU. So actually there are several ongoing randomized clinical trials, and we will see the results of all of these studies. You can see very well that there are several studies for all the drugs that has been discussed today: lopinavir, ritonavir, remdesivir, darunavir, favipiravir, umifenavir, chloroquine, methylprednisolone, tocilizumab, Akira, and even for plasma. So we will see if for the end of the year we will be able to say something about which is the best drug for treating COVID-19. So before conclusion, let me say something about the other infections, the super infections. And we know very well that the more recent data show that there was a very high prevalence of secondary infections, 50% in non-survivors, 1% in survivors, and they represent the key contribution to mortality. In the majority of the cases, we are talking about bacterial secondary infections. And when you look at the heterogeneity of prevalence incidence infection across study, obviously there are too many differences in the sample size, in the different diagnostic procedures, and also in the reduce of the diagnostic approaches. However, what we can say is that in the past 3 months, at least in Italy, but overall, there has been an intensive use of antibiotics in all patients with suspect or proven COVID-19. And you can see very well the antibiotic use was dramatically high in all the patients. And this is, my opinion, a very important point to be discussed, because we probably abandon in many centers the antimicrobial stewardship concept that were developed in the past years. And I believe we have to go back to improve our effort for improving the antimicrobial stewardship approaches in our hospital, despite of the COVID. So which are the recommendations? It might be prudent to consider empiric antibiotic therapy in critically ill patients with pneumonia due to COVID-19, in when bacterial infection cannot be excluded. This suggestion is based on the fact that bacterial co-infections is common in patients with viral pneumonia and can be associated with the substantial risk of delaying appropriate therapy. The last point before conclusion is that which is the role of fungal infections. And you can see very well that we recently published with a group of colleagues in the Lancet Microbe about the role of aspergillosis in COVID-19. And as you can see, I was one of the authors with Paul Vervey and with Cornelia and Oliver Connelly. And you can see it's important to consider the potential role of Aspergillus in COVID-19, as we did in the past for flu. So there is an important increased risk of our patients to develop aspergillosis, particularly pulmonary aspergillosis. And my suggestion is that to consider this important risk and to perform adequate diagnosis procedure like BAL for the GM, for galactomannan, and the CT scan. Thank you very much for your attention.
Thank you, Professor Bassetti. And I would like to address just several questions from the audience. First of the question is related to favipiravir. So the question is, if given the lack of the peer-reviewed studies or indeed double-blind placebo studies done globally with this drug, what is your opinion in its use over the antivirals? So, you know, actually, regarding the different antivirals, the favipiravir, hydroxychloroquine, and remdesivir, the only drug that should be recommended to be used remain remdesivir. That is the only drug that has been approved for using in COVID-19. So favipiravir has been studied by the Chinese and the Japanese colleagues. However, we don't have the same strengths that we actually have for remdesivir. So the drug has been approved by the FDA, and EMA is going to approve the drug soon for the rest of Europe. And I really believe that remdesivir, even if it's not the ideal drug, because we have to think about the potential role of antivirals, don't forget that it's very similar to the effect that we have with the oseltamivir. Even oseltamivir is not the best drug. The oseltamivir reduce the length of fever and the length of duration of the symptoms. Doesn't have any particular impact at the end on mortality. Okay, so and this is similar for remdesivir. So it's not easy to treat an RNA virus, but in my opinion, actually, if I have to suggest a drug to be used inside of randomized clinical trial or inside of protocol, it remain remdesivir. Okay, thank you. And next question is about methylprednisolone. When do you recommend to start the use of methylprednisolone? Very early. So we decide to use methylprednisolone already in the emergency room. So then the drug has been continued by our colleagues in collaboration with Paolo Pelosi and his group. And you know, Paolo, we decide to prolong the duration of the steroids. Maybe can be discussed later by Paolo. But in general, in my opinion, it's very important to start early. So it's important to start probably in emergency room or in a first phase of the disease. And probably the last question about the convalescent plasma. In your opinion, which is the optimal time to start, the volume which should be administered, and for how long time? So actually, to the best of my knowledge, we don't have enough evidence for plasma. So we must perform adequate randomized clinical trials. Otherwise, we are in the total empirism regarding the use of plasma. So I don't really know how much IgG you have to have inside of the donor. We don't know how much bags we have to give of plasma, for how long. So all of these elements are completely unknown. And I hope that actually there are, in my country, at least two very important randomized clinical trials. One that is conducted by IFA, that is our National Agency of Drugs, and the other is developed by Pavia Hospital and Mantova Hospital. And I hope that they will be able to include a sufficient and adequate number of patients in order to say plasma works or not.
Otherwise, we have just anecdotal report about plasma. So we have used with Paolo Pelosi one patient that was very desperate, and it was a desperate use. And but I believe that we have to be cautious regarding the plasma. Probably should be helpful, but we don't have enough. We don't have actually enough element to support its use. So we must perform randomized clinical trial adequately conducted, and if at the end plasma will demonstrate to be superior, no problem to use plasma. But now we have just anecdotal reports.
Okay, thank you, Professor Bassetti, for your presentation and for the answers. And now to invite Professor Paolo Pelosi to share with us his experience of his team about the ventilation of COVID-19 patients. Professor Pelosi, stage is yours.
Thank you. So I will share the slides now and the screen. So we should go. Okay, do you see everything? Fine?
Yes, Paolo.
Yes.
Okay.
Perfect. Thank you very much for the invitation. It was a pleasure to hear all these lectures on COVID-19. And I will discuss a little bit about the experience on how to ventilate these patients that we had, of course, together also with Matteo. No conflict of interest in this setting. This is just a reminder of which is the timeline of COVID-19, and that showing clearly that around 5 to 12 patients need intubation or even more in some setting, and quite a number of patients require prolonged mechanical ventilation, while a minority really at the end require tracheostomy. And the duration of ICU ventilation is quite long, especially when the disease does not resolve within the first 3 weeks. This is the coronavirus, as all of you know, and at the beginning it was called like coronavirus disease 2019, like COVID-19 pneumonia. So it was supposed to be pneumonia and just affecting the lung from mild to moderate to more severe lesions in the lung. Then there was more evidence that it was not the full picture, and at the beginning it was focused mainly the attention on the cytokine storm with release of interleukins and alteration in the immunocells. This was also mentioned before, leading to fluids in the lungs, but also on the changes in the vascular side with increased hypercoagulability and increased platelets aggregation associated with increase in the dimer. So the vascular leakage, the clotting and inflammation, and all together were defined by another Italian group like microclots. So the attention was given mainly to the vascular side. We are proposing a new picture like multiple organ disease syndrome and called MOTS-CoV-2. So like real invaders of all organs, as shows is in this picture. So not only the lung, not only the coagulation, but also all other organs may be affected, like the liver, the gut, the kidney. We have seen some data before, the heart, and in some patients also the brain. So it's really a more complex disease that we believed before, and this is just an example in our unit. This is Dr. Balbusa, cardiologist with the echo, looking every day at the heart function, and then you see the CRT, so the renal support, you see the ECMO, you see the ventilator, of course, you see pumps. So just really treating a very multisystemic organ disease and not only related to the lung. These are a very recent data that we got with our team. This is led by Professor Fiocca and from anatomopathology and Dr. Barisione from pneumology. And as you can see here, mainly in the picture A, you have lesions in the different epithelial cells with some inclusion in the different inflammatory cells in the alveoli. Not much edema inside. Then you can see in the other pictures a lot of fibrosis, and very interestingly the picture F, where you can see the alteration in the vacuolization of the epithelial cells, and the interstitium, the red cells that you can see are smooth muscle cells, so means that the activation of fibrogenesis is so active and dishomogeneous that may produce even different type of cell that you don't expect in that particular area of the lung. So what we can define here is that there is a major pneumolysis, not much edema, not much microthrombosis when patients are analyzed after 25 days of mechanical ventilation, and a lot of fibrosis and necrotic cells. So fibrosis seems to be extremely important to lead the final death of these patients. And this is in the early diffuse alveolar damage. You see here in the black above the abnormal area of the epithelium cells and the alveoli. Then you can see on the B panel a major alteration and disruption in the alveoli, and in the C panel the hyaline membrane. This is the so-called relatively normal areas at the CT scan in our patients. Then you can see the mid-dead pattern. You see completely altered anatomy of the alveolar and interstitial side with a lot of fibrosis, and you see where this pattern mainly in the dependent part of the lung, and the late dead pattern you see when you have these white areas completely full of fibrosis that you even don't recognize anymore the vascular side. And this is extremely important to interpret now on how to ventilate this patient, to interpret our CT scan in vivo data, while all these data were taken by cryobiopsy during mechanical ventilation 20 minutes after death of these patients. And also we analyzed some areas very peripheral that were mentioned also before, and we found a complete remodeling of this area, the parenchymal structure, by fibrosis and mucinous filling of the alveolar space. So what we found at the CT scan, and how can we interpret this anatomopathological data with the real CT scan in patients in vivo? We found 3 phenotypes. The first phenotypes with multiple focal overperfused ground glass opacities and normally aerated areas. A phenotype 2, which was characterized by atelectasis and peribronchial opacities, unhomogeneously distributed and hypoperfused, and these are also associated with phenotype 1, and phenotype 3 with patchy RBS-like pattern with unhomogeneously distributed and hyperperfused areas. The phenotype 1 was less frequent as compared to phenotype 3, and we believe that, for example, non-invasive ventilation and eventually prone position, we will discuss that, might be effective in phenotype 1, but non-invasive ventilation should not be applied in phenotype 3. And then we will discuss later the role of mechanical ventilation and PEEP in these different patterns. There is a progressive alteration, like from phenotype 1 to phenotype 3, from early to late phase. So these are not really different patterns of the disease, but just the evolution of the same disease. This is an important pattern if you consider the interpretation of the changes at the CT scan. So in critical ill patients, phenotype 1 was rare, while phenotype 3 was more frequent, as you can see here, and in phenotype 3 may evolve in pneumolysis, in fibrosis, and as discussed before, in sobreinfection and complicated with EAP. And there are also some evolution after extubation. This is a patient with the consensus of the patients. It was one of the patients, first patient that we extubated. And these patients at extubation with much better clinical improvement, we found a major alteration of the CT scan within 5 to 15 days after extubation. This patient will be followed up, but this effect is present also in at least 30 to up to 50% of the patients that were extubated after severe disease. So this is another important issue that has to be considered into account. Of course, we observed gross thrombosis in COVID-19 in around 15 to 20% of the patients. This is an example with a saddle gross thrombosis in the pulmonary vessels with a peripheral thrombus also. And this is, of course, has to be considered. Then we move to the CT scan and CT perfusion to better understand the pathophysiology of COVID-19. You see here our higher resolution CT perfusion, and these were the first CT perfusion that we observed. And substantially, we found possibility to combine the CT scan, so looking at the gas volume and the tissue volume that you can see on the left, and the regional pulmonary perfusion in these patients. Overall, we found that the lung weight is around 800 grams in normal lungs. In the typical RDS lung is around 2 kilo, so 1,800 grams. In COVID-19 phenotype 1, that you can see in the upper part of the panel, the average lung weight was around 1,100 grams, so around a little bit more than 1 kilo, while the phenotype 3 that you see below, the lung weight is around 1.5 kilos. So the typical RDS lung is much, the weight is much higher as compared to phenotype 3 in COVID-19. Now, this is a little bit complex slide, but I'd like to discuss into detail because it's extremely important to understand the pathophysiology of COVID-19. You can see the lung tissue, the pulmonary gas volume, and pulmonary blood volume separated in hyperaerated tissue, which is not a major problem in these patients, normally aerated tissue, poorly aerated tissue, which are the typical COVID-19 ground glass areas, and non-aerated tissue. And in the dash bars, you can see the area with perfusion defects, so there is no perfusion in that area. So we found that, first of all, the non-survivor versus survivor were characterized by older age, as expected, and as discussed before, and higher Charlson index. But what about CT between people who died and people who survived from the ICU? First of all, non-survivors, as you can see from the green bars, were characterized by lower normally aerated tissue, and we can expect from also previous studies in RDS. The higher total lung mass, as I told you before, the weight of the lung is much higher, is around 500, half kilo higher in non-survivors compared to survivors. Then you can see here that the pulmonary blood volume was much higher in the poorly aerated tissue. So this means that there is overperfusion in the ground glass areas, and this is one of the major reasons why you observe a reduction in oxygenation in this patient. Also very important, we found that the areas of perfusion defects, so no perfusion, were higher, as you can see in the orange bar in non-survivors, in the poorly aerated tissue, and in the patient and in the non-aerated tissue. So there is an increase in the hypoperfusion in the poorly aerated tissue, so the ground glass areas, and in the non-aerated tissue in non-survivors. The other important point is the distribution of lung tissue, pulmonary gas volume, and pulmonary blood volume from ventral to middle and dorsal lung regions. from the first part on the lung tissue, you see that the COVID-19 patients present a progressive increase in non-aerated tissue in the dorsal lung regions, and also an increase in the hypoperfused areas from ventral to dorsal. On the other side, this was associated with a reduction in the aerated tissue. So what does it mean? That is that the gas volume is progressively substituted by non-aerated tissue, while the fully aerated tissue, where the ground glass, are more or less uniform from ventral to dorsal lung regions. And this substitution is not edema, is fibrosis and cellular necrosis. This is a major difference compared to RDS. The pulmonary gas volume decreased, of course, progressively from non-dependent to the dependent lung regions. But more importantly, the pulmonary blood volume, as you can see here, followed a non-gravitational pattern. So there was much more blood in the ventral lung regions, where we have less, we have even more aeration, and we have less pulmonary blood volume in the dependent lung region, which is completely the opposite of what happens in normal subjects and in conventional RDS. And there was, however, higher blood flow in the non-aerated tissue, especially in the dorsal lung region, explaining the higher amount of shunt. We found also a correlation between normally aerated lung mass and the D-dimer and C-protein C and the PO2-FR2, as expected. We also found, interestingly, that the poorly aerated tissue was associated with C-proactive reactive C, and the non-aerated lung tissue was correlated with the D-dimer, the C-proactive C, and PO2-FR2, while the poorly aerated lung mass was the only one correlated with the compliance. And the lung mass with perfusion defects were correlated with D-dimer and C-reactive proteins. So this means that the amount of fibrosis, so the increase in the lung mass, and the perfusion defects are associated with increased thrombophilic events, markers, and increase in inflammation. We also found that the application of PEEP from 16 to PEEP 8 was not associated with major recruitment, which again explained the fact that this increase in lung mass is not due to edema, so poor alveolar recruitment with higher PEEP level in less severe cases, but different what is being suggested by the editorial right now, but without any data, we found the same in the more severe cases. So higher PEEP is not associated with recruitment, as occurs in conventional RDS in COVID-19 patients. And this is just to remind you what happens with the flow, diversion, and recruitment between supine and prone position. In the first panel, you see a case of patients in which you have no recruitment, so the densities remain near to the vertebra in supine or prone position. So if you have an increase in oxygenation, but no increase in ventilation, so no changes or even an increase in the PCO2. And this is typical of COVID-19. While in conventional RDS, traditional RDS, as you can see, we observed from supine to prone a recruitment of these areas, so increase in ventilation, so the improvement in oxygenation was associated with a reduction in PCO2. So this means that if PCO2 increases during a prone position, this means that there is just a redistribution of perfusion without recruitment. If PCO2 decreases with prone position, this means that there is an effective alveolar recruitment. So these are some data from non-invasive ventilation and prone position published recently, and you see that there is an increase in oxygenation, saturation, and decreasing in respiratory rate when patients were submitted to non-invasive respiratory support in prone position, but these effects were lost in most of the patients when the patients were positioned in supine position. Our data from prone to supine during non-invasive ventilation suggests an improvement in oxygenation, but not maintained with time, a reduction in lung volume, an increase in tissue mass. So the improvement in oxygenation is mainly due to a redistribution of perfusion, but not recruitment. So prone position during non-invasive ventilation is not associated with major changes or even deterioration in the lung morphology in COVID-19. This was a study that we performed some years ago in traditional RDS, and you see that the patient who survived had a better response in PCO2. So the patient who decreased PCO2, indicating an effective alveolar recruitment in prone position, they survived, had a better survival, while survival was not associated with a response in oxygenation. What we observed with prone position in COVID-19 patients, that 40% of the patients improved, at least 20% improvement in oxygenation during prone position, but only 20% of the patients maintained an improvement in oxygenation where repositioned supine, and 77% of patients increased PCO2. So this means that the improvement in oxygenation in COVID-19 is mainly due, in prone position, is mainly due to a redistribution of perfusion and not recruitment. And also this may deteriorate further the oxygen transfer due to the Haldane effects on saturation when PCO2 increases and pH decreases. As you remember, at the same pH, at the same PO2, when the lower level of pH are associated with less oxygen saturation. Also, prone position may be associated with a risk of higher thrombosis and pulmonary thromboembolism that has to be excluded before positioning these patients, increased demand and workload. And from our data, there was no evidence that patients who were actively prone had a better survival compared to patients who were not prone. Of course, lung ultrasound can be used in COVID-19 in place of CT scan, even if we believe that CT scan and CT perfusion, of course, give much more detailed data, but at the bedside for daily routine monitoring, lung ultrasound may be extremely helpful. So these are my last slides to show you our model that we developed of COVID-19 pneumonia. This is what happens in normal subjects, in low PEEP, high PEEP, and prone position. The blue are the alveoli, the red is the perfusion. In the normal condition at low PEEP, we have more ventilation in the non-dependent part of the lung and more perfusion in the dependent part of the lung, but all of them are well aerated. With high P, we over-distend the lung, we squeeze the blood volume, and when we prone the patient, we have better ventilation in the non-dependent lung region in prone with better perfusion. What happens in RDS? In RDS, as you can see, we have a reduction in the lung volume due to the edema, and we have atelectasis in the more departed part of the lung, and so with higher perfusion. So this is the fact that in conventional, traditional RDS, we have more edema, more atelectasis, more perfusion there, and this explains the high shunt in these patients, and not much low VQ areas. When we apply PEEP, as you can see here, we may over-distend the non-dependent part of the lung, but we recruit the dependent part of the lung. These are real atelectasis with higher amount of perfusion, so we can improve the shunt, so we can reduce the shunt, and we improve the ventilation perfusion mismatch. When we prone traditional RDS patients, what happens, you see the black area become blue areas, so we recruit the lung in the dependent lung region, now non-dependent, in prone position with more perfusion that is maintained in the dorsal lung regions, and this is associated with the improvement in oxygenation. So in the traditional RDS is characterized by edema, atelectasis, lower compliance, higher perfusion in the dependent lung region, recruitment with higher pressure in supine position. Response in oxygenation is always associated with better aeration and recruitment, but not perfusion redistribution. What happens in COVID-19 is a completely different pattern. As I say that COVID-19 is not traditional RDS, eventually it can be called as clear primary RDS. So as you can see here, you see the blue areas, blue circles are the aerated lung, the small blue circles are the ground glass areas, the black circles are some pneumonic consolidated areas, and you see that at the low PEEP in COVID-19 in the type 1, so less severe form, initial form of the disease, we have more perfusion in the ground glass area, and more perfusion in the aerated area. So the first fact is that we have a low VQ due to the hyperperfusion of ground glass areas and ventilated areas in the non-dependent part of the line. If you apply higher PIPA in these patients, we do not recruit anything, but we just redistribute blood volume, and this might be associated in some cases in improvement in oxygenation if we redistribute blood flow towards the hyperinflated areas, but this is mostly not the case, and this is mainly associated with reduction in oxygenation. When we prone these patients, we can have some improvement in ventilation, we maintain some blood flow in this area, and we can have some improvement in oxygenation, but mainly due to redistribution of perfusion. And this is even more evident in the type 3, and you see the purple circle, which represent the fibrotic areas, or full of necrotic cells, and with some purple areas here also lines which represent the thrombosis. So you see again that the main cause here of hypoxia in COVID type 3 is the presence of blood flow in the consolidated areas, is the presence of blood flow, higher blood flow in the ground glass areas and in the normally aerated areas. When we apply high PIPA, we don't recruit at all, so completely different picture from traditional RDS. We can change the redistribution of blood flow with some transient improvement in oxygenation. And when we prone the patient, we don't observe any recruitment, and so we just have some redistribution in case of perfusion towards the other areas. And of course, if there is too much ground glass areas, we don't even observe any improvement in oxygenation. Another possibility is some minor recruitment, but this minor recruitment is associated very often with peripheral vascular capillaries thrombotic, so with no any effect in better perfusion in this area. So in COVID-19 is a typical primary RDS with pneumolysis, gas volume substituted by fibrosis and cellular necrosis, consolidation with higher perfusion in non-dependent lung regions, with poor and no recruitment, with higher pressure and response in oxygenation associated mainly with redistribution of perfusion, but not better aeration and recruitment. So in COVID-19, our model from our CT scan study suggests that hypoxia is due to the lower VQ in the aerated, non-dependent and poorly aerated lung tissue, homogeneously distributed in the lung due to an increase in the perfusion. This is completely different from what observed in the traditional RDS, and with higher shunt in non-aerated lung tissue, but consider the microthrombosis effect that in some way we have some protective effects. Of course, if microthrombosis is too much, this is negative from the lung. Which are the difference from survivors to non-survivors? As I showed you before, in non-survivors, and also explained it here in the graphics, lower amount of aerated tissue, higher amount of total lung mass due to the mainly of fibrosis and consolidation, and not atelectasis, higher blood volume in the poorly aerated tissue, larger amount of perfusion defects in poorly and non-aerated lung regions. So with this are the overall conclusion here. So mainly COVID-19 is a systemic complex disease. COVID-19 is not a traditional RDS. Is a first bullet is a pneumonia as a primary RDS and with pneumolysis. As a second bullet, coagulation with thrombosis and hemorrhage. As a third bullet, fibrosis, and as mentioned by Professor Bassetti before, anti-inflammatory, antivirals, perhaps anticoagulants, and protective respiratory support are important. In critically patients, the phenotype 3 is more frequent. The phenotype 1, there is an inhomogeneous pattern of aeration from volume distribution and perfusion defects. Pulmonary microbiological pattern, blood volume and perfusion defects are associated with clinical outcome, inflammatory and thrombophilia markers. Higher PIP was not associated with recruitment. Prone position was not associated with recruitment, but redistribution of perfusion. Lung imaging technique, including CT perfusion, in our opinion, should be considered for diagnostic and therapeutic assessment of COVID-19 patients. So overall, how to ventilate COVID-19? We have to be very patient with these patients. In phenotype 1, we can try non-invasive ventilation, but early, and if there is no improvement, defined as respiratory rate higher than 28 breaths per minute and saturation below 95%, SpO2 higher than 60%, we have to start mechanical ventilation. In phenotype 1, not improving non-invasive ventilation, and phenotype 3, we need early intubation and control mechanical ventilation. We should use protected tidal volume between 6 to 8 meters per kilogram predicted body weight and plateau pressure below 27, PEEP below 8 to 12 with use of higher FiO2, minimize oxygenation targets between 55 to 85 with higher hemoglobin levels for oxygen transport. And in phenotype 3, try prone position, but very cautiously, no recruitment, higher PCO2, recruitment maneuver only as a rescue. These are the conclusions on which are our suggestions on how to ventilate these patients according to our recent data on CT scan and CT perfusion. Thank you very much.
Thank you, Professor Pelosi, for your presentation. And we have several questions about the anticoagulation. What regimen for anticoagulation drugs will you recommend?
Yes, I did not discuss that because, of course, it was not in the topic. We used the D-dimer to monitor the activation of coagulation in these patients. And when the D-dimer was higher than 1,000, we started with enoxaparin. Not only a prophylactic, but also at a therapeutic regimen, so around 4,000 times 2 or 6,000 times 2. Then if the D-dimer increased more than 5,000, there was a progressive increase in the D-dimer up to 10,000, 15,000. We started to use heparin intravenously between 20 to 25,000 units a day. We constantly look at the echocardiogram, and if you have some suspect for gross thrombosis or deterioration in oxygenation, we started with the use of thrombolysis, and then thrombolysis was followed by the use of warfarin. And we use the new anticoagulants as a follow-up when the patient was discharged. So we use also the activated factor 10 to monitor and to target the use of heparin in these patients.
Okay, thank you. We are a little bit out of time. Because of that, I will switch to the next speaker, and I will ask Professor Adrian Belli to talk about the perspective of infection in Republic of Moldova. Professor Belli, the stage is yours.
Hello, good evening. I apologize for my late coming to the meeting. I was at the Ministry of Health where I give some advices when I asked to give them. So I'm not so well prepared for this meeting because just 2 days ago I was informed about it. I'm not prepared like PowerPoint presentation, but some observation and some opinion about strategic and general management of COVID patients and what kind of practices we have in Institute of Emergency Medicine. So today we have in the country 10,300 active patients, 371 deaths, and today we have 296 new cases confirmed. And also under active monitoring, we have around 39,000 patients under monitoring. In general, we have a mortality rate in the country 3.5, 3.6%, but in the Institute of Emergency Medicine, we receive the most difficult patient from the whole of the country, and we use oxygenotherapy, non-invasive ventilation, and mechanical ventilation. So mostly of our patients have comorbidities. Have severe comorbidities like obesity, diabetes, hypertension, and general mortality in among our patients in intensive care is 24%. The statistics is given already on 400 patients who passed through us in 75 days that we analyzed. And among mechanically ventilated patients, we have a mortality rate 80%. So we use on most of the patient prone position ventilation. We use anticoagulation in therapeutic doses. Mainly, we use Flexan and Fraxiparin. We use also heparin. Concerning antivirals, we didn't observe improvement using Plaquenil or using Caletra, but we have already 27 patients who receive convalescent plasma. I'm not ready to communicate about it is good or not good to perform this kind of treatment, but it is a state program, and we should make a study on this treatment. And also in patients with cytokinic storm, we use also methylprednisolone or dexamethasone, and some element of MARIC protocol like high doses 6 grams and above of vitamin C and thiamine. The average mechanical ventilation days is around 16 to 18 days. So in general, this is the situation. Concerning epidemiology, we have around 2,000 medical personnel in the country who is infected, and the explanation is multifactorial. At the beginning, we had no enough protection materials, but actually and in my observation too, is we have no good culture of hand washing and fight against nosocomial infection and against contact infection. So this kind of knowledge, and not only theoretical knowledge, but practice who will evolve to evaluate to institutional culture should be achieved in nearest future. And in general, we have a shortage of physicians, of nurses. We have a lot of students from university who help us, but in general, most of physicians and doctors, all of them are very tired working inside. So in general, this is the situation in Moldova, and I will discuss after the meeting with my colleagues to be in to actualize the information what was exchanged here before I could enter online. So this is my short communication.
Okay, Professor Valeriu, thank you for your input. And now I pass the Dr. Ruslan Baltaga, the president of the Valeriu Ghereg Medical Foundation.
Thank you, Ion. Your Excellency, Ambassador of Italy to Moldova, Valeria Ghereg, distinguished professors and panel members, dear colleagues and friends. My name is Ruslan Baltaga. I'm Associate Professor at the Chair of Anesthesiology and Rheumatology #1, Valeriu Ghereg, from the State University of Medicine, Nicolae Stiințanu. I'm Vice President of the, and immediate past President of the Society of Anesthesiology of Republic of Moldova, and President of Foundation of Valeriu Ghereg. The foundation was established actually on basis of Chair of Anesthesia with contribution of disciples, colleagues, and friends of late Professor Valeriu Ghereg. During pre-pandemic times, we were focused on supporting education, mainly in anesthesia, and some projects dedicated to persons in need. For instance, the latest event we've organized in conjunction with Society of Anesthesia was Conference in Memoriam Professor Ghereg, the 15th edition, with participation of invited speakers, Professor Gurman, Wexler from Israel, and we had a workshop on difficult airway with Dr. Gabriela Godoroja from Bucharest. In response to spread of COVID-19 pandemic, Valeriu Ghereg Medical Foundation launched the campaign, "The Country Needs Intensive Care," as an effort of auto-organization and contribute to reduce effects of the avalanche, taking into account realities in medical system in Moldova with many pre-pandemic deep problems like low economic resources, prolonged reform, staff shortage and migration, failure to implement high standards of care, and so on. So three priorities were identified in frame of this campaign, and the subsequent actions and projects were carried out. So first priority was increasing the protection capacities of personnel from the intensive care department, mainly from our Chair of Anesthesia, involved in the treatment of critically ill patients with COVID-19, and several measures have been taken in this action. The modified technique of intubation was implemented in partnership with the industrial company. We've manufactured and donated to several hospital intubation boxes. We fundraised and donated video laryngoscopes. At the beginning of March in country, we did not have any video laryngoscope available. One of the first was donated with contribution of Dr. Ludmila Fortuna by a donor who wanted to stay anonymous. As well, training and simulation was promoted and organized on PPE, intubation, and other procedures. We contributed to donation of PPE, disinfectants. We were identifying local resources because import was difficult at the time. In order to reduce the risk of infection of members of the families of the staff, we carried out various actions of accommodation, provision of food, provision of food for medical staff from Emergency Medical Institute who were accommodated at Center of Rehabilitation, and other well-being activities were organized. We organized as well transport from staff members, especially from those living in suburbs, because during weekends, public transport was not operating. We have elaborated and installed a video surveillance and communication system for COVID-19 patients. So second priority was screening, testing of staff from the intensive care unit involved in the treatment of patients with COVID. We fundraised and procurement tests services for staff, which initially were tested only if were systematic. This action has several components: screening and early identification of infected people, even asymptomatic, thus reducing the risk of infection among other medical workers, and as well psychological effect for staff who are concerned about their health, but especially about their family members. And third priority, but not the least, was contribution to strengthening and optimization of treatment measures for critically ill patients with COVID-19. Among actions, I'd like to mention prone position implementation, training, and fundraising for support devices for prone position, which were not available in hospitals. Implementation of the ultrasound during lung focus technique in diagnosis of and management of COVID-19. We've contributed to fundraising and procurement of an ultrasound machine dedicated to intensive care unit. Implementation of ultrasound guided apneoistic technique of tracheostomy, donation of 15 pulse oximeters for doctors at Hospital of Ministry of Health, donation of consumables and parapharmaceuticals, fundraising for an ozone machine. The project is ongoing. We are in negotiations with Livebox Foundation for pulse oximetry donation for hospitals which need them, including Transnistria region. I'd like to mention that we are identifying not only the problems, but offering some solutions for them. And as everyone, we have learned in changing conditions from ongoing changing situation. Many projects were as seeds and were developed later by other organizations for which we are proud. For example, intubation boxes, screening of medical staff, which is being done by hospitals now, procurement of video laryngoscopes, ultrasound machine, and so on. All projects were possible with implication of various stakeholders: Chair of Anesthesiology, #1, Valeriu Ghereg from State University of Medicine, Nicolae Tistinițan, Society of Anesthesiology and Reanimatology, hospital administrations, volunteers, donors, and I'd like to express our gratitude for everyone's contributions. Details about our foundation you can find on website viamed.md and on Facebook. Plans for the future: all projects I've mentioned above are ongoing. And since pandemic is climbing up, as Professor Belli mentioned, 293 is the record high number of cases in one day in Moldova, so the slope is going up. We've recently elaborated a project of dissemination of experience gained to and distribute to regional hospitals by combining both online and on-site simulation-based training. And we are looking for partners and sponsors for further support of our activities. And finally, I'd like to thank for the idea of for the webinar and to all contributors and participants to this webinar. Thanks to AFAM, Italian Embassy to Moldova, and the distinguished speakers. It was very, very useful webinar for all of us. Thank you very much.
Thank you, Ruslan. And we have some questions. Professor Paolo Pelosi, do you have any experience, or maybe you are aware about the use of ozone therapy for the treatment of COVID-19 patients?
Yes, I wrote something. Yes, there are some centers in Italy that they adopted. The data are rare. There are not well done studies. We did not use, even we could have the possibility as to be approved by the National Drug Agency. Personally, I think that is something that if there is an effect, is only to be applied very, very, very early, not in the later phase. And the data are not actually coming from well-done studies. So I would be extremely cautious, as Professor Bassetti mentioned, for other drugs.
Okay, thank you. Dr. Ruslan Baltaga, the early warning system Accord developed by the Society of Anesthesiologists in Ireland has shown great results in preparing for supporting departments, hospitals nationwide. Could be considered by Moldova with infrastructure support by other partners?
Sorry, I had some disrupted.
We have.
Can you repeat, please?
Yes. The early warning system Accord, developed by the ICU consultants and Society of Anesthesiologists in Ireland, has shown great result in preparing for repurposing departments, hospital nationwide. Could be considered by Moldova with infrastructure support by other partners?
Yes, of course. That would be useful for implementing, and we could consider in the curricula of the project we mentioned about the dissemination of the experience. So we include we'll include their checklists, the Lifebox and WFSA checklist for the anesthesia, and I think that would be useful.
And another question for our experts. Maybe Professor Massimiliano will answer us. What is your opinion about regarding the timing of tracheostomy in COVID-19 patients?
This is a very good question. I have some personal opinion. I have some evidence-based opinion, but I think that Paolo can answer even better than me to this, because they published an excellent paper on Lancet Respiratory Medicine for the timing of tracheostomy, the issues of tracheostomy. Basically, what I can say is that there's a lot of debate. There's not a univocal point of view. There's a general advice to postpone tracheostomy in these patients, but my personal opinion is this is not the wrong approach, but we need a robust data before we can give definitive answer. For sure, Paolo can add some more on this issue, because they did a really great study. I think you also showed the graph, because this answers to the timing issue, no?
Yes, tracheostomy, there are some few studies that we published. This was an international review. There is another study. We are collecting all the data, comparing the timing and the effects. So actually, our experience, we treated almost more than 150 intubated patients in San Martino, and we are just the last 6 now. We did tracheostomy in the minority of the patients, and tracheostomy was performed in all of them at least after 2 weeks. I can say that our time was around 20 days. Because as I showed before, you have to be patient for at least 1 week, then you can start weaning. And if you are going well, so the fibrosis is not progressive, that's my feeling, as I showed you by the CT scan data and autopsy data. okay, you are moving well, so why to perform tracheostomy earlier? It's not like other disease. If your fibrosis is progressively, and so you have very difficult weaning, you can be in mechanical ventilation for even 1 month, 1 month and a half, up to 2 months. Now we have patients 2 months and a half, and even ECMO. We have cases now in ECMO just after 40 days again in ECMO. So at that point you need the tracheostomy. So I think that this is the balance around between the 2nd week and the 3rd week. You have to decide if you are going well, okay. If you are not going well, you have to expect at least other 15 to 20 days, 1 month longer in terms of ventilation. Regarding the technique, we use both, but we found that there were some concern at the beginning about percutaneous at the bedside, but we did in 90%, we did percutaneous without any problem. There are some, of course, tricks that you have to consider, but percutaneous is our first choice.
Yes, and if I can add a comment to this, I think that as a general rule, tracheostomy should be considered later than in conventional situations, and above all, you need a team. I think that Paolo performed this bedside percutaneous tracheostomy because he had a team which was used to this. But if you're, for your first experiences, if you are not such an expert in these techniques, probably a further delay and the choice of surgical technique is better. I mean, it's really complex issue because we don't have data, we need to understand. The sensation is late tracheostomy, and if you are confident with it.
No, I agree with you.
Can I make a comment?
I was thinking about the team. I mean, for me, it was not a problem because we are very experienced in tracheostomy, and so there's no problem. We did also surgical because with our Torino surgery, but all surgical that we did, and now we are comparing all the data with other centers, we had some problems in terms of infection, problems of stomach, and the conventional problem with surgical. But in this patient, we did very few. But now we are collecting the others that did surgical. My impression that we had more complication with surgical than percutaneous. But of course, I fully agree that you need to do percutaneous. You need organization and the team to do that safely.
Can I add a comment?
Yes, please.
I would like to say about this issue of tracheostomy in view of our realities. We've adopted an early tracheostomy, and this is because at current situation, we have a nurse looking after 5-6 patients. They can be intubated, or I mean in ICU patients, because of lack of and shortage of nurses and doctors as well. So it's very difficult to maintain a sedated patients. Imagine the line would kink or anything, so patients would get extubated. So after 4 or 5 days, when we realized that this is going to be a longer than 10 days ventilation, we electively are doing ultrasound, a modified ultrasound apneoistic technique. Dr. Ivan Kverzik is here, who is one of the first who did it. It takes about, and all of them are percutaneous, takes less than 2 minutes to do ultrasound apneoistic perc tracheostomy. And I want to stress, this is because of realities to look after multiple intubated patients in our situation.
Okay, thank you. And one more question about sedation and the use of neuromuscular blockers in mechanically ventilated patients, COVID patients.
We of course in the early phase we received very sick patients. So I've seen before the graph from Cecconi. I mean, all our patients, they had a PO2 ratio below 100. So that's our patient in the ICU. So very sick, and in the first days, these patients must be kept deeply sedated and paralyzed, and eventually with or without prone position, but has to be this. then what we did, differently from some others, we tried to reduce sedation, however, after the first few days, and to try to reach assisted ventilation as early as possible. But this depends again on the evolution of the disease. So if the disease is going better, you can follow the patients, otherwise very difficult. But we try to reduce afterwards, after the few 2-3 days, the use of neuromuscular blockade agent, because we use corticosteroids. Bassetti mentioned that, and so we have not we have to balance both of them. Regarding sedation, we use the conventional one, but we tried again to go to assisted ventilation, mainly BiPAP. We use a lot of BiPAP in the weaning phase, and we use dexmedetomidine also in the after 10 days due to the fact that the weaning is very difficult in these patients, and so you have to balance different type of drugs. But I think that we have to use sedation and neuromuscular blockade agent in the very first days, but then try to wash out as early as possible, of course, if possible.
Yes,
but I don't agree with people that say, okay, you have to keep the patient relaxed for 1 week. No, you have to be relaxed for a few days, and then if you can to move. Then if you have a problem, you can go back. But try to get some chance every day to the patients, because otherwise the risk is that you stuck the patients paralyzed, mummified, I can say, and this is very bad for the patient. And why I don't like too much prone position. We did prone position, I show our data, but and we have also the CT scanner like this, but the question is that prone position is always associated with a lot of sedation and paralysis. So if it's absolutely needed, okay, but it's a workload, the PCO2 increases, it's not like prone position in the RDS. So the combination between too much sedation and paralysis compared to faster assisted ventilation, we prefer to go to faster assisted ventilation. So this is, I don't know what is right, but I think that some regulation, some rules that we adopted for RDS has to be a little bit reconsidered in COVID-19.
Yes, and if I can add a comment, I totally agree with Paolo, especially in light of the association with steroids. So you might pay the price of critical illness, weakness, or neuropathy or myopathy. So really, they are important, but prudently, and trying to go to spontaneous or to assisted ventilation as soon as possible. For intubation and IO instrumentation, neuromuscular blockers are mandatory, full dose, and if you can also have a monitor, that would be great, so that when you intubate the patient, to be sure that it's fully paralyzed, so that you can reduce any coughing or bucking or whatever, which is an aerosol-generating procedure. So totally agree with Paolo, particularly for airway maneuvers, deep pluralization.
Okay. Thank you. And oh yes, we have one more questions. Do you do echocardiography before proning the patient?
Echocardiography is mandatory in this patient always, not before proning or not. For sure, proning is for thromboemboli, but echo is mandatory. In fact, I show you the slide with our cardiologist. He was very passionate for our patient. We were very lucky for that. He was not the only one, but one of the most in looking at all our patients, and this is absolutely mandatory. We have a lot of information about embolism, right atrium, if you PEEP that you are using. Why we started to think, because at the beginning, when we went the first intubate the patient on February 29, okay, not so far from what Cecconi showed in Lombardia, no, February 21. So just 6 days later, and we did not know almost anything. And echo was essential when we found, say, I have to use IRP, you have to use prone position, you have to use recruitment, so the conventional RDS. And we put the echo, and you see the 16 of PEEP, the right atrium become like that, even worse than the normal RDS. That's why echocardio is essential in this patient, whatever you do.
Not only, I add that ultrasounds are essential in this patient, because because we had a couple of members of our team, particularly funded experts with ultrasound, so daily basis for echocardiography, for lung assessment, for intubation check, for renal resistive index.
Also, you have also you have to look in some patients the problem for the nerval optic.
Retina. Yes.
We did, for example, one study that are coming on the renal, for example, because you know renal is a problem. So it's not a problem in the beginning, but then when the patients are maintained for mechanical ventilation for longer time, then our experience is almost 35% of patients they require CRT. I showed in one example I have another picture. We have patients all with CRT, but these patients after 1.5 months of mechanical ventilation. So the kidney is another major target of this disease, but later, not in the early phase. In the early phase, you say, oh no, the kidney is not so much, only the drug or like this, but when mechanical ventilation for a longer time is a real problem.
Okay. What do you think about antibiotic prophylaxis in early stages of disease?
Antibiotic prophylaxis? Bassetti discussed, this is a big discussion. In our center, due to the discussion with Bassetti and his team, we decided to use ceftaroline, an aggressive against gram-positive and pneumococcal and some gram-negative. In other centers, they decided not to use prophylactic antibiotics. It's a difficult issue. What I can tell you that using this strategy, our impression is that really in the first 20 days, you reduce 14 days, you reduce the risk of sobreinfection. The problem is that if the patient, they continue for a longer time, this may increase the risk of sobreinfection. So it's a balance between these two factors. And of course, there are no clear answers on that. There were different strategies. You can do one or can do other. The important is to monitor, and when you have a deterioration during the ICU course, to me there are two possibilities. One is the sobreinfection, the other is thromboembolism. So these are the two factors that you have always to look for when you have a deterioration in these patients.
And this choice depends also on how fast and open is communication with your laboratory. So if you can easily perform tests, if you can repeat, so if you have a closer monitoring, as Paolo said, your choices will be more precise because it's a balance. You give antibiotic, you have prophylaxis, but you select resistant bacteria, whatever. So it's very delicate, maybe case to case. So discussing with the lab and repeating tests is very important.
Bassetti did not, I had no time to discuss, but the main problems are methicillin resistant Staphylococcus aureus, gram-negative, and not much Aspergillus, but Candida.
Yes.
Even Candida auris can be selected here. So these are the three main microorganisms, more and more resistant with time, because at the beginning you have not resistance, but after 3 months, especially if you have patients lasting more than 2.5 months of mechanical ventilation or ECMO, this may become a problem, but can be limited. It's a limited number of patients who develop it. This is a question of time.
And probably the very last question, again about proning. If you consider to prone a patient, for how long you will keep him in prone position?
No, you have to use all the balance very, very, very hard. So we kept the proning for a long time, for at least 15 to 18 hours a day. Because you have to play, if you want to play with prone, you have to play very hard. Few days, very hard. The problem is that, as I show you, many patients in our experience, and now I see other centers, we are going to publish all this kind of stuff, they increase the PCO2. So if you increase the PCO2, because as I showed, the prone is not like in RDS. The prone here is mainly a redistribution of perfusion. So to me, prone is mainly a rescue. If you have very low level, you prone the patient and you try to do what you want. But short time, you cannot do for 3, 4, 5, 1 week. Short time, long for a few days in a longer time. The other point that was not discussed is the use of nitric oxide. We had 3 machines, of course we could not use in all patients, but we have also very good data on the use of nitric oxide. Of course, just symptomatic, not related to improvement in survival or a major clinical outcome. But as a rescue, also nitric oxide was very effective in almost 80% of our patients.
We did the same as Paolo said. So when we perform pronation, it's very challenging for nurse, for everything, with risk, with everything. So once we did it, we kept for not less than 16 hours. If we have to look at the past and something to learn for the future, probably we should get better in selecting those patients who really benefit from pronation. So we became more selective. So we did the less pronation with more patients we had, but once we did it long lasting, and how Paolo said, I mean, you need to fight hard. So maybe better to spend some more time and have more resources to understand which patients will really benefit.
I agree fully with Sorbello, because I think one of the major problems, we try not to do that because we started with the mentality of not recruitable lung on average, as I showed, and our CT data confirmed this. But at the beginning, I've seen photos, with all patients proned in one ICU. I don't think this is a good approach for COVID-19, starting from organizational point of view, but also from clinical point of view, because this is not, as I show you, a typical case over there. So I fully agree that probably we have to understand more who, but just as a rescue, but in a limit. So prone is not the magic word for COVID-19. This is a sort of message.
Yes, and I see some questions coming on the chat, and I think that we can easily collate these points. I mean, my feeling, and I think that Paolo will share it completely, we were facing a totally new disease. We tried to understand what was new, but only going to the basic helped us. So echocardiography, physiology, trying to understand, being patient, I mean, giving the body the time to fight the virus. So our role is probably try to keep the body safe, adjusting small things and everything. And so I think that the magic bullet is just high quality intensive care. It's not pronation, it's not this, is following infection, is a big gentle with ventilation, taking care of the kidney. So our role is just high quality intensive care. It's no magic bullet, no pronation, no hemofiltration, no nitric oxide, whatever.
Just to make a short, because then I have to leave, unfortunately. I fully agree on this. And if I can summarize our experience, I consider finished. We have the last 6 patients, but now we are fully relaxed. Is that COVID-19, he likes disorganization. Yes. He likes too much activity. While if you want to fight in intensive care, COVID-19, you have to be very relaxed, very patient, take your time, and this is the best way against COVID-19. He likes fun, and we have not to give fun to him. This is just, I know that Sorbello likes the joking sometimes. It's a tragedy, this story, but we learned a lot that we need experience, but we need also not to go too much sometimes and to be more relaxed and wait time.
Okay.
Can I say hello to everyone because I have to leave?
Bye.
Goodbye.
Thank you very much.
Guys, it was a fantastic meeting.
Ciao, Paolo.
Ciao, bye.
I would like to thank to all our invited speakers, to Professor Paolo Pelosi, to Professor Maurizio Cecconi, to Professor Massimiliano Bassetti, and to all our partners from Moldova, to Embassy of Italy in Moldova. We would like to thank you for your time, for your decision to share with us your experience. And I support the invitation of Dr. Ludmila and hope that we will be able to see you soon in Chișinău in a live meeting, and we will be able to continue meetings like this in the next future. Thank you to everybody and have a nice evening.
Thank you.
Grazie.